and medical powers of attorney. I'm going to talk about the limitations of living wills a little bit as an introduction to saying how important it is to have these conversations with your power of attorney and your loved ones. And this is kind of based on my clinical experience, and I'm going to use green eggs and ham. I'm absolutely stealing this from a colleague, a doctor named Ronn Huff, who wrote an article years ago on this same topic. But I want to talk about this just a little bit, and then talk about what I think are some better directives than what are out there. You'll see a lot of directives, ones that are promulgated by states, including the state of Tennessee. There are other directives out that are available that I think you'll find are much better, including the Caring Conversations packet that Dr. Wasserday distributed. So, are you familiar with the book Green Eggs and Ham? Is this a book that you have read to kids? Okay, so classic Dr. Seuss. So you know the premise, right? The little annoying Sam I am trying to push this weird food item onto the person who keeps saying no over and over. If you analyze the book, like Dr. Faro did, he says no 70 times in 13 different scenarios. Not in a boat, not on a boat, not on a train, not on a plane. I don't want green eggs and ham anywhere. Of course, the punchline of this book is that the person who I'm putting as a patient here never tried that, right? So all these hypothetical scenarios, would you like this in this situation? And no. And then he tries them, and of course he likes them in the end. How does this tie to advanced care planning? No matter how much planning you do about thinking about different medical states, medical conditions that you're going to be in, it's never quite the same as when you have them. And this is the old Spanish saying I like to quote, the bull looks different when you're in the ring. When you're sick, when you're sick and your family members are coming to speak for you, it's an entirely different experience than when you're sitting in a nice Brentwood library contemplating hypothetical medical scenarios. It's much more difficult. Living wills are kind of modeled on the estate planning. Organize your ideas in advance. Here's what I'd like to do this scenario, this scenario, this scenario. Making decisions about health care, I think, are a lot harder than regular estate planning for most of us. They're premised on three things. One, you really have to know what you would want, okay? Now, it's easy for me to say, if I'm actively dying, please don't keep flogging away at me, okay? That's pretty easy to say. In fact, that's kind of the standard of care now, to allow someone like that to die peacefully without pain with hospice care. You don't even really need a directive for that. But if you get a stroke and your neurologist says, I don't know how much recovery you'll make, or how much your spouse or your mother or your brother or sister will make. Very hard for a directive to address that issue. If you have mild to moderate dementia and you develop a breast cancer, do you want that treated? Do you want it even diagnosed? There's so many different scenarios that living wills are not very well designed to cover, but these are decisions that you absolutely will have to make, or loved ones will have to make for you. Your preferences have to stay consistent over time, or you have to keep on filling these things out over and over. And there's a lot of data that we've encountered over the years that shows that people who fill out living wills subsequently get sick, they change their preferences dramatically. And then 6 to 8 months after being out of the hospital, they change them again. So these are fluid ideas, and these are fluid values. And so in order to have a very good, impactful directive, you have to change it a lot. Okay? So this is something that we know because we've actually tracked people for decades now who do these. And this is an important one. There's a lot of pressure on physicians, particularly in hospital settings, to be able to accurately diagnose and prognose your illness or the progression of your disease. This is not easy. This is not easy for physicians to do. And so in a situation where you might need that living will acted on, there's often a pause because it's hard for physicians to sometimes make this call. A very prominent palliative care physician, Joanne Lynn, answers addresses this issue very, very well. When asked, how long do I have, doctors are often inarticulate. Two patients with the same amount of heart damage and the same array of concurrent illnesses may have very different lifespans for largely unpredictable reasons. So dying suddenly in the midst of long-term chronic conditions is a common pattern for the end of life. A lot of pressure in the hospital when families talk to physicians and say, is my dad going to make it? Are we in an end-of-life scenario? And doctors, very accomplished doctors, will say, I'm not sure. And thus, usually treatment will follow that, and in retrospect, you may say, that was too much. In the moment, very difficult to make that decision. And you'll see trajectories here. I'm not a physician, I won't go into these, but you see the trajectory of functional decline in different types of deaths. And when you're looking at organ system failure, when you look at dementia or frailty, at what point on that continuum is it time to honor a living will? Very difficult, increasingly difficult to make that call. With an end-stage infectious disease or cancer, a lot easier. So back to green eggs and ham. This is one of the big issues. When we talk about advanced care planning, you see these living wills that will say, what do you want in this scenario? What do you want in this scenario? And those are all well and good. You can put your preferences down on paper, but the key question that doesn't get asked, and if you remember the story, green eggs and ham, the person keeps saying no. What does this little annoying person, Sam I am, never asking? Why? Why don't you like it? Right? He just keeps on offering different choices and scenarios. But the question is never invited into dialogue. And dialogue is incredibly important. Patients have all sorts of reasons for filling out directives. As adults, we want to maintain control. This is a very quintessentially American, although not exclusively American, value of hyper-independence, where we don't want to be a burden on anybody, right? Some people don't trust physicians. Some people don't trust their family members and fill out directives to protect themselves against overzealous or under-involved family members. Don't want to be a burden. Once again, this is this fierce American rugged individualism. I don't want to be a burden. You're probably going to be a burden. How it works out. Wanting to avoid a low quality of life. Not just end-of-life scenarios, but at a certain point, if I'm 90, stop taking me to the hospital. It's okay. I'll stay at home. Don't call 911. There are scenarios that aren't just involved with end-stage illness, where people don't want to go into the cycle of hospitalization, or what we call death by hospitalization, over and over. So it's not just about disease maintenance. It's about quality of life and not having a medicalized end of life, which is what our culture does. Some people fill out directives that say, this is kind of rare, but we'll fill out directives that are called will to live directives, which is, I want everything. I've made it this long, damn it, I want everything, don't withhold anything from me. And those are tricky, and I don't encourage those necessarily, but I certainly encourage the attitude of living as longly and robustly as possible. So what's important when you're doing directives is to ask this why question. Looking at your goals about in life, the goals that correspond with quality of life and what you'd like, and focusing less on would you want a feeding tube, or would you want to be placed on a ventilator. Looking at these broader goals and then allowing your proxy and your doctors to interpret how does that apply to this particular medical situation. In my experience, has been a much more effective approach to take than a purely legalistic one that says, oh, he said he wanted treatment for heart disease, but not for cancer and this and that. Those tend to lack the nuances that are necessary. Once again, relationships matter. In this book, according to Dr. Seuss experts, this is the only main character of any Dr. Seuss book that never had a name. And this is exactly what people are like. In the hospital, patients are like this. We don't know most of our patients. Most of us don't have an outpatient relationship with patients and families, and that's important. Okay, a lot of times we substitute information for relationship, and these are incredibly important decisions. What type of medical treatment and intervention we want, how we manage our dying process. These aren't just perfunctory estate planning things. These are incredibly personal, for many people, religious, or certainly at least family decisions, and they defy easy categorization. So a lot of times doctors are not paid to do this. We tried to expand Medicaid compensation for voluntary end-of-life counseling. It got labeled death panel, and it got taken out of the Affordable Care Act. There's a real cultural reflex and a real cultural taboo still about talking about death and dying in our culture. Voluntarily talking about it, paying doctors to help their patients talk about it. We're still in a really regressive regressed state here in the United States on this topic, and it's unfortunate. So as a result, we're not compensating and we're not encouraging doctors to help lead these conversations in the outpatient environment. And that's not going to change anytime soon, unfortunately. And when we do talk to patients, a lot of times we exclude the family. So, and of course, this guy says, I don't like this person. I don't even like this person pushing me for all these answers. And this is the response you get in the hospital a lot of times. We're asking people, what is your father's code status? What would he want hospice or not? And there's no relationship to ask these incredibly personal, incredibly important questions. And so the living will model falters a lot in the hospital. So I want to focus in on the importance of relationships as we talk about end-of-life planning, okay? Because this is crucial. And I've got a few exercises here in one video I want to show you. Living wills are limited. You have to have them. You have to know in advance what wishes you want. You have to be able to clearly state them. The documents have to be available when you need them. Once again, one of the big issues is I have some life-limiting illnesses, and I am found down in my home. What's to keep people from calling EMS and me being intubated on the way to the hospital, and all of a sudden the cavalcade of aggressive treatment start? Okay? You have to have documents available, and this is the big one. You have to have your family and your clinicians read, understand, and follow the instructions. Okay? I'm blessed to work with some very good doctors who do this. A few of them in the room here. Not every doctor is going to take a lot of time to do this unless you, as an advocate for your loved one, will tell them, we need to read this, we need to discuss this, or I need to switch to a doctor who will take the time to do this. This is very important when the hospital setting. I know there are more than a few physicians who do. Please, in a situation like this is a responsibility of your doctor. Make them take the time to discuss these things. These are not perfunctory decisions. These are conversations. But your family has to follow them too. I don't know why these are following off the screen, but that's very cool. So I want to alert you just really briefly to a handout here. On a form that says patient instructions, I want to talk about the idea, if you're going to do a directive, some recommendations. One, I've seen a lot of traction from this book called Fidelity, Wisdom, Love. And I've got it's actually I won't pull it out. It's actually a workbook that you can order on Amazon.com. The people that developed this, the main doctor that developed this, whose name is escaping me right now, Joe Finnis, from Cornell Weill in New York City, found out that through research, that having conversations about your wishes are a lot more impactful if you do them with the person who's going to be there to enforce them. And so this is one of 4 scenarios that this book works with. Now, this is a book that will take you a little while to work out with your proxy, but there are 4 different scenarios. One's Alzheimer's disease, one is stroke, one is cancer, and one is congestive heart failure. And there are, of course, other disease trajectories that could be included. They focused on those 4 ones. So they start with this scenario. And you can read the scenario here. About 6 years ago, you begin to notice you were becoming more forgetful. One time you got lost driving home from the store and had to ask for help from a policeman. You called your children and told them what had happened. Your children urged you to see a doctor, and test reveals that you have early Alzheimer's. At that time, you appointed your son as your healthcare proxy. In Tennessee, what's called a healthcare agent. Your children tried to look after you, but after a few years, you were full-time care and had to go into a nursing home. In the last year, you no longer recognize them when they come to visit you. You're given drugs to control agitation and for problem sleeping. A few days ago, you became very ill and were taken to the hospital and put on a ventilator to help you breathe. A pulmonologist is called in and believes that the illness that brought you to the hospital is quote-unquote treatable. So you're not dying, okay? If you were the patient, would you want to be removed from the breathing machine? Okay? Or would you want to be put on the ventilator? So these are the type of scenarios we're talking about that typical advanced directives don't focus on. Here's a person who may be, quote-unquote, pleasantly demented. Not dying, but has lost for what a percentage of us would consider a baseline quality of life, which is I no longer meaningfully recognize my loved ones, my family, my friends, my ability to interact with my environment is minimal, it's transient. Would you want medical treatment in this scenario or not? have the opportunity to answer these questions. The neat thing about this type of scenario is that you're having your proxy also fill it out, preferably independently of you. And then you come back together and compare notes. And it's not so much to see if my spouse correctly predicted what I would want, but mainly to come back and look at the difference in values. I talk about advanced directives to clinical audiences on a periodic basis, and it's usually more nurses than doctors. And I ask nurses in the group, how many, most of whom are women in the groups I talk to, how many of you have healthcare power of attorney? And a fair amount raise their hand. I say, okay, how many of you are married? After a certain age, a lot of them are married. I say, how many of you have appointed your husband to be a proxy? About half the hands shoot up. Because one of the answers you get is, I love my husband, but he would keep me, stuck on the mantle with various lines to keep me alive forever. So I have my sister do it because she's more rational, she's more reasonable in these situations. So you have to choose the proxy that either knows your wishes or has the clarity and the courage to honor them when the time comes. Now this is tricky. You have multiple children. You don't want to pick and choose among children, and this is a problem for us mediators in the hospital setting. We'll get these handwritten directives that say, all of my children are equal proxies. Okay? So we all have to agree, and that's hard to do, right? So pick one. It doesn't mean you're excluding the others. So we have 166 registry errors. We're not going to fix those now. We're not going to exclude loved ones from the conversation. In fact, your proxy is going to need that support if you have other people in your family or other friends to help make these decisions. Trust me, these decisions are hard to make when your loved one is actively dying. Dr. Patel could vouch for me on this. These are hard decisions to make when there is no decision to be made because it's your loved one and you're in the ring and it's very difficult. You want that support, but you want the one person who is going to think and understand your thought process. Once again, when you fill out something like this, you're talking about why. Why do you want to be on that ventilator? Is life sacred to you where even if your mentation is at such a limited level, you still feel life is sacred and you'd like to live as long as possible? Explain why. If you would not want to live in that state when Alzheimer's has erased your functional memory and your baseline ability to interact with your environment, explain why. That provides a great deal of clarity and comfort for your loved ones. Establishing leeway in your directive is important. Once again, this involves some writing and some discussion. For people who want to live as long as possible, this is important because these are legal documents, and doctors are chilled by these things. Okay? In this environment, in this increasingly litigious environment, you go and waiving a living will or a healthcare proxy, doctors pay attention. Hospital administrators pay attention. They hire little people like me to come in and nuance these situations. This is serious business. So you have a directive, or you don't have a directive for somebody, but you're their proxy, and they want to live as long as possible. What happens if they can't? You have this document that says, I want to live as long as possible, and your infectious disease physician says, these conditions are incompatible with life. Your loved one's not going to survive more than a few weeks or a month. Do you provide leeway for your proxy to override those wishes? This is really important, and this is not implied in living wills. Write this in. I give my proxy complete discretion to override me if she thinks that it's in my best interest. Or don't do that. If there are some non-negotiables, you're Jehovah's Witness, and you say no blood or no blood products, no leeway. Right? But leeway is important. How much discretion do you give your loved one and your physicians in real time to nuance a situation that you didn't think about and that's not in your living will? Very important. Once again, kind of an American Norman Rockwell-esque idea of dying is you die at home, in the bed, with the dog, with your loved ones around you, your children, your grandchildren. It's a nice idea. It's not always possible. For people who want to die at home, one nice thing in the directive is, what if it's too difficult to get that hospital bed in there, to get those home health resources? Is it okay if if we send you to hospice? Is it okay if we go somewhere else? Once again, establishing leeway for the people that have to make these decisions in real time, very important. And these aren't always addressed in living wills. So there are copies for most of you for Caring Conversations. I think this is a wonderful resource. Once again, it takes time. If you fill out a 10-page or 15-page directive, you're also going to have your doctors read it or change to a doctor that will. Okay? Ask your nurses to prod them. The good doctors will read them independently. Most of the doctors will read them with encouragement. They're very busy in the hospital setting, but they will go through them. The American Bar Association's Toolkit for Healthcare Advanced Planning, all these are free online. These are great resources, and they go through this kind of question-answer dialogue process, which is key. You'll learn things about dying and death scenarios that you never even thought of. Okay? And it doesn't have to be that depressing. It actually can be kind of interesting. And there'll be some things where you don't know. And for those ones you don't know, leeway. I give my proxy leeway to make that decision for me. I'm going to stick it to my kids. They're going to have to make a lot of tough decisions for me. I'm not going to make it that easy for them. Because I can't think these things through. One final thing I want to show you today in my time is that researchers are finding different ways to do advanced care planning. The living will proxy model is very heavily dependent on a literate patient or literate family. It's a lot of reading, it's a lot of writing. This was an initiative that was started up in the Boston area by a group of researchers out of Harvard to use video in advanced care planning, to see if it would have an impact, to actually show functional health states on video instead of just reading a description. And I'm going to show you one that's about 6 minutes long, and I won't bore you with the design here, but the scenario is about advanced dementia. So not just Alzheimer's, but the advanced stages of dementia, okay? And the 3 different possible goals associated with care that you're being asked to choose from is life-prolonging care, that means everything, resuscitation, ICU care, the whole 9 yards, limited care, which is maintaining our physical functioning, but precluding 911, mechanical ventilation, resuscitation attempts, ICU care, or comfort care only. When I get advanced dementia, all I want is to become comfortable, ideally out of the hospital when at all possible. Okay, so you can see that on a page. If I get advanced dementia, what do I want? This video is probably not going to stream live, so what I want to do is go to the video and show you the video intervention here, and then show you the results. And this can be a jumping off point for our discussion. Let's see if I can find this.
I'd like to talk to you about what it's like to have advanced dementia, like advanced Alzheimer's.